Magandang umaga po sa kanilang lahat. Good morning. Good morning. First of all, I would like to thank the organizer and the officers of the PIDSP for inviting me over here. Actually, this is one of my commitments when I was still the director of the National Center for Disease Prevention and Control, which I cannot really delegate to other officials of the department because the invitees are really very good friends. And they are closer to my heart. So I really cannot delegate this. Right now, I'm wearing two hats. I'm speaking in behalf of the government, and at the same time, I'm also temporarily seconded to UN agencies to look after the UN Joint Program for Maternal and Newborn Health in the country. The professionals, especially the pediatricians, have a very critical role in helping our country to make sure that our commitment for the Millennium Development Goal has been reached. And therefore, looking at your interest, which is the child or the children's health, I would like to present to you some inputs and some thoughts on how collectively, as government, as private sector, or as a health sector as a whole, would be able to protect our children, the Filipino children, from diseases and promoting their rights to health and rights to live. So, is Dr. Monteliano here? Okay. So I would like, of course, to congratulate the society headed by Dr. May Monteliano, and of course, Dr. Lester Diniega. If I remember it right, you were one of my professors in UST. So, siguro hindi naman ganun kalayo yung gap nung age namin. No? But I remember him because I only remember good professors. So, check. Okay, so going to my keynote lecture, let me present to you because I know that I was told by Nancy that I have to look at the expanded program on immunization of the country. However, we have to go beyond EPI in order to protect our children. So, talking about how EPI protects the Filipino children, let me go through the major milestone of the expanded program on immunization in the country. And we know that vaccination or immunization would really protect our children from these infectious diseases that are really preventable. Now, the EPI program in the country started in 1975, wherein almost all of the antigens, the basic antigens, are being given by the public sector. So, antigens against polio, diphtheria, pertussis, tetanus, measles, and anti-measles, as well as the tetanus toxoid for our mothers. Now, one of the milestones that we had is that when the Philippines was certified polio-free in October of 2000. And this was made possible by achieving a very high immunization coverage of 3 doses of OPB before the child reaches 1 year old, and the good surveillance for polio. So, nowadays, you could rarely see young children with this disease. Another commitment, international commitment, is measles elimination. Now, we all know that measles is a very deadly virus and it's very contagious. And prior to vaccination, it was recorded or estimated that there are about 14,000 Filipino children dying every year because of measles. And there were an estimated 1.4 million children who have been infected with measles during those years. Now, if you could see our... Okay, malabo yung pointer. So, if you could see, from 1980 through the years, when we are increasing the coverage of our measles immunization, the number of measles deaths also decreased. And this is an unprecedented decline of measles case. When we started, when we started doing our mass immunization campaign, so you have heard about Ligtas Tigdas campaign, no? So when we started our Ligtas Tigdas campaign in 2004, then you could see a marked reduction of our measles cases by 96% the following year. Meaning to say, we were able to reduce the pool of susceptibles because of mass immunization of our children against measles. And also, during that time, between 2004 to 2005, there was no confirmed measles cases. In 2006, we saw one confirmed measles case. And during that time, we tried to do reaching every barangay strategy, meaning to say, a special team would go to barangay, then make a grab sampling of some children in the church or in the marketplace or in the school to check if they were immunized the previous years. And in 2007, we are now looking at more than 100 confirmed cases. Because during these years, we don't want to be complacent just because we are seeing reduction in measles cases and deaths. But rather, we want to make sure that the surveillance at the hospital and facility level is very active. Meaning to say, any child presenting with symptoms like measles should have their blood sample be taken and be confirmed for measles. Also, in the past 15 years, more children are protected against tetanus, and cases have also declined. So if you're going to look at the coverage of measles, of tetanus toxoid among our women, the neonatal tetanus cases are also decreasing. However, because of our commitment to eliminate neonatal tetanus soon, so we look at the high-burden provinces or high-risk provinces. And these are the 9 highest risk provinces for neonatal tetanus. So, meaning to say that babies born in these 9 provinces remain at risk of dying due to neonatal tetanus. So, if accidentally you are living or you are practicing in this area, please help us covering this area. So, meron ba sa inyong taga Basilan? Basilan, Sulu, Lanao, Maguindanao, Abra, Cotabato City, Lanao Norte, Benguet, Isabela City, Basilan. So these are the 9 provinces that we are targeting for mass immunization effort to eliminate maternal and neonatal tetanus. Hepatitis B. So, it has been stated that around 300,000 Filipinos are chronically infected with hepatitis B, and there are about more than 9,000 deaths per year. Now, among these cases, 40% were infected at birth, while 30% of these, more or less, were infected in their first year of life. So, a hepatitis B vaccine first dose should be given at birth within 24 hours, followed by 2 more doses before they reach their first year. So, this simple immunization strategy would prevent 90% of hepatitis B infection. So, the goal of eliminating this by 2012 is really challenging. We are now 2010, and the requirement for us to be declared with hepatitis B elimination is that at least we have to cover 80% of our birth dose, no? And 80% should have been covered with 3 doses of hepatitis B vaccination. Now, because of the cost before, the government, the Department of Health can only provide 40% of the total requirement for hepatitis B vaccine. However, when we had an increased budget in 2007, we were able to procure 100% of the vaccine to cover all eligible populations. And when I say eligible population, these are children less than 1 year old. Now, when you look at the sentinel sites of the Department of Health, there was really no infants or newborns given birth dose of hepatitis B. However, our latest data in January of 2009, there were 71% of those infants born in the facilities under the sentinel sites were given hepatitis B. On the other hand, only 20% of home births receive a dose within 24 hours. And if you're going to look at the proportion of our deliveries at home, this is really low. Now, 80% have already received 3 doses of hepatitis B vaccine. Now, good news. The 2008 National Demographic Health Survey, which is an official health survey in any country, showed that we really made an unprecedented success in our immunization. We have reached 80% fully immunized children. In the past NDHS, which was in 2003, this is only 70%. So a 10% increase in the interval of 2 National Demographic Health Survey is really very impressive. Actually, we don't, sabi nga namin, although maganda yung figure, this is not really a cause for celebration. Why? Because we still have around 20% of children who are not fully immunized. And therefore, you're going to translate this into numbers. There are still hundreds, thousands of children who are not reached by our immunization. And if they are going to be pooled every year, then we would have a very high pool of susceptible children in the future. That's why, even though the National Demographic Health Survey says that we are high, can see now some outbreaks of measles in some parts of the country, especially in Manila. Now, this is just to show you that all countries in the world are doing their demographic health survey. Now, these are different countries. Sorry if you cannot read them. But if you are going to look at the Philippines, in 2003, this is our status among these countries in terms of FIC. And in 2009, we are here. So, we all agree that vaccines can save tens and thousands of lives every year. But then, how safe are our vaccines? So, the vaccines that are being used or procured by the Department of Health is being bought through the UNICEF procurement system. We don't bid it in the country, we source it internationally. And of course, UNICEF would ensure that the vaccine that the country will be buying are really safe and effective. They should underwent good manufacturing practice, and they should meet all the critical indicators required for pre-qualification purposes, following the World Health Organization independent assessment and reassessment. Now, they should be coming from manufacturing country with a functional national regulatory authority. So, meaning to say, this national regulatory authority in the country of origin of the vaccine should be independent of the manufacturer, no? So, parang ito yung ating BFAD or FDA. They are independent of the manufacturer. They are being assessed also and reassessed by the World Health Organization. They monitor and test vaccines for safety and efficacy. They are doing the licensing and the regulatory functions and inspections. And they also do post-marketing and adverse events following immunization surveillance. So, we make sure that the vaccines that we are procuring through UNICEF procurement system are coming from countries with very functional national regulatory authority, and at the same time, the manufacturers are certified to be CGMP. Okay, we also upgraded our cold storage facilities. Even though we ensure or we are assured that the vaccines are really safe and effective, if the cold chain is not being followed along the line of transport from manufacturer to the delivery to the child would be a problem. So, we make sure that our cold storage facilities in the countries are upgraded at the national, at the 17 regional offices, and at 82 provinces. So, this is the type of cold chain equipments or storage that you can see at our Research Institute for Tropical Medicine, which is our national storage. And then also at the regions. So, at the provincial and city health vaccine room, you could see these equipments and storage. Aside from this storage, there are also some high-tech devices that monitors the temperature of the vaccine. So, we always make sure, and we are very strict on this, in every region and in every provinces, there's what we call cold chain manager. And they make sure that the vaccines are really kept on their right temperature and the stock level is at its optimal. Meaning to say, at the regional and national level, there should be at least 6 months stocks of the vaccine. At the provincial, 3 months. At the primary health centers or rural health units, at least 1 month. And at the sub-center, such as the barangay health stations or in the community, you have at least 1 day supply during that immunization day. And our vaccine have this vaccine vial monitor, VVM, that really tells the vaccinator if the vaccines were exposed to high temperature. So this is the optimal. The square one is clearer than the surrounding round. So this is the most optimal vaccine, no? So ibig sabihin, you can still use this vaccine. If it becomes a little bit darker but still lighter than the outside circle, you can still use the vaccine if the expiry date has not been reached. However, if they are already of the same color, or if the square is darker than the round color, circle color, then you have to discard the vaccine even though the expiry date has not yet been reached. Another strategy that to make sure that the vaccines is safe is the monitoring of adverse events following immunization. Actually, all of us who are providing immunization are mandated to report any adverse events following immunization. So, what is an adverse events following immunization? It's a medical incident that takes place after an immunization, causes concern, and is believed that it could be caused by immunization. Now, these adverse events are being reported and investigated through our AEFI surveillance system. So, this investigation is a rigorous causality assessment process that reviews the data, determines the need for further investigation, and underwent rigorous epidemiological investigation and evaluation. So, what could be the causes of AEFI? First, it could be body's reaction to the vaccine. So, that's where you could see some local vaccine reaction, all allergies, or anaphylaxis. No? Second, could be error-related to the way the vaccine is being given. And this is what we call program error. No? So, it could be due to unsafe injection practices or unsafe storage of the vaccine. The third one could be unsafe manufacture, which is now, at present day, exceedingly very, very rare because of the new regulations that being implemented globally. The fourth could be the fainting upon injection. Ito yung mga injection reaction na biglang hinimatay nang makita yung karayom. No? And then, of course, lastly is coincidental. And most of the adverse events that are being reported and were being investigated are mostly coincidental. So, none of these were proven to be really vaccine reaction. So, in reality, most preventable AEFIs can be due to unsafe injection practice and storage practice, which are really preventable if the providers or health workers would be conscious enough to observe the proper immunization and vaccine storage practices. So, these are just some of the pictures of unsafe storage. You have to make sure, even at your private clinic, that the vaccine rep is dedicated to the vaccine alone. It's not also, para tong for official use also, no? So, the vaccine rep should only be for vaccine. So, there should be no food, fruits, chocolates, and other food there, no? Baka yung mga nagkukonsulta, nagbigay ng itlog, ng cake, or ng hamon, papasok sa vaccine ref, no? So, this is an unsafe vaccine storage practice. Sometimes, you could see this. The spoiled vaccine still inside the ref. And sometimes, pag nagmamadali, when you're in a hurry to provide immunization, especially if the children are already lining up, you might mistakenly get this spoiled vaccine. This is also a no-no, a pre-filled syringe. Sometimes also, dahil sa dami ng mga bata, the health workers or practitioners are anticipating that there would be long lines of children and therefore they would pre-fill the syringe. Now, I know in the private practice there are already this pre-filled talaga. Hindi yung inaspirate lang, no? Which is much safer than the ones that you are aspirating from the vial. Also, eto, we had one case of adverse events following immunization. Now, when the epidemiological surveillance was conducted, it was found out that the midwife who is doing an outreach immunization brought, of course, meron siyang vaccine carrier, no? The aspirating needle was left in the vial. And when this vial submerged into the water, kasi natunaw yung yelo, so may tubig na lang doon, of course, this could be contaminated. So this is a very big no. Inappropriate handling. We now provide safety boxes. The safety boxes is the box wherein you would put the syringes and needles. Sometimes, we can provide hub cutters. Yung hub cutters is the one which can cut the needle portion from the syringe. And therefore, you don't have to unscrew the needle. No? So, this is one unsafe practice wherein the health worker is handling all the used syringes with bare hands. Another one is the inappropriate cooling packs. We have what we call cold dogs. No? Now here, you could see that there's this styrofoam, there's this open vial of vaccine, and there's this ice in the plastic. No? So, these are inappropriate cooling packs. And inappropriate disposal. No? In health facility, there should be parang nicho, no? Wherein you can put all your syringes there. So, kasi in the health centers or in the rural areas, you don't have there your proper hospital type autoclave or incinerator for these waste materials. So, dito makikita natin, there's an inappropriate disposal of syringes, which is being mixed inside the common waste basket. Okay, so, if you're going to look at the number of children's deaths, you could see that based on our 2008 National Demographic Health Survey, 25 infants die per 1,000 live births, and 34 under 5 children die per 1,000 live births per year. Now, if you're going to recompute this, some mathematical computation, this means that 140 children die every day due to other causes, diarrhea, pneumonia, sepsis, no? Poisoning, injuries, etc. And this translates into around 1,560 infants dying within 3 days after receiving an immunization from causes not related to the vaccine. So, this calculation only showed us that sometimes deaths of children who were immunized within 3 days, who died, no, most of the time, they are being attributed to immunization, when in fact, they are not. No? And the surveillance data showed that most of these deaths are really coincidental because of other causes of deaths. So what are the gems of the immunization program? We have this Executive Order 663, which is the first ever presidential declaration to strengthen routine health programs. And this only strengthens our attainment of our commitment to eliminate measles and neonatal tetanus, as well as continue and sustain our status of eradicating polio and control hepatitis B and other preventable diseases. This also strengthened the surveillance system and clarified what is the role of the midwives in terms of immunization. Now, this executive order has been followed up with an administrative order which serves as the implementing guidelines for this executive order. And this reiterated the precaution for unsafe injections among our health workers. It also specifies some legal support for those health workers that could have had some cases, legal cases because of adverse events following immunization. And by doing this, the Philippines is the 13th country all over the globe and the first developing country with policy on legal assistance. And also, it ensures that all health workers adhere to safe and effective use of vaccine. The executive order and the administrative order covers both the government and the private health providers. Okay, budget. This is in US dollars. When we started in 2006, this is where we only have 40% of our hepatitis B, aside from our routine antigens. And we were only enjoying then about $9.27 million budget for immunization. In 2007, when it was increased, we decided to buy 100% of our hepatitis B requirement. In 2008 and in 2009, there was a tremendous increase of $8 million from 2008 budget. And that's the time we procure MMR and 40% of pentavalent vaccine. In 2010, our budget would be $21.8 million. And this would increase more procurement and coverage for pentavalent vaccine and MMR. So this would be distributed all over the country. So, vaccine saves life, and we are all supporting safe vaccination for our mothers and children. But then, that's just one intervention. Immunization is just one intervention. So, how are we going to protect our children beyond EPI? Our Millennium Development Goal Challenge is really basically on MDG 4 and 5. The MDG 4 states that we have to reduce our under 5 children's death by 2/3 by 2015. If you're going to look at our National Demographic Health Surveys through the years, it is decreasing, but the rate of decrease is really not that much. But we can see here that between 1993 and 98, there was only 11% decline. 26% in 2003, a big decline in 2008, 37%. But between 2010 and 2015, we need to reduce this death by 67% in order to achieve our commitment of reaching 18 under 5 deaths per 1,000 live births. Now, if we're going to look at our infant mortality, it's also showed us the same picture. There was a decline, but still we need to have this into a very steep decline. Now, if we're going to look at our under 5 and infant mortality, we can see here that more than 50% of our under 5 deaths are really occurring during the first year of life. If you're going to crunch this data, we could see that 2/3 of our infant mortality happened at the newborn period during the first 28 days of life. And therefore, our national policy is to really strengthen our maternal and newborn health intervention. So when you look at the direct causes, these are mainly preventable. Some of these can be addressed by our immunization. But then, 53% of these deaths have underlying undernutrition. And when you're going to look at the neonatal deaths, which is around 37% of overall under 5 deaths, you could see here that preterm, prematurity, asphyxia, sepsis or pneumonia still top as the primary causes of death among our newborn. And this can be related to the practice of newborn care, to how we take care of the pregnant women that can affect the outcome of the delivery and newborn health. So, what are the underlying causes? As practitioners, we have to go beyond our clinical eye. We have to go beyond our clinical practice. Let's go public health sometimes to understand why our patient keeps on coming to the hospital, why our patients keep on dying. Some of them are dying. So, underlying causes are inequity. There are highly marginalized urban poor. And there are also those living at the geographically isolated areas. There are constraints in funding for child survival. There are poor compliance to laws and regulations. We have so many laws in the country supporting child health. Diminishing health human resources. Where are our doctors? Where are our nurses? It's good. We are now graduating 37,000 nurses, no? Who passed the board. But where are they? How can we employ them so that they can contribute to our health system? And of course, the fragmented local health system delivery. So, how the rich and the poor child access health services? If you're going to look at the percentage of children with acute respiratory infection symptoms who sought treatment from health facilities, you could see that majority of those in the richest quintile would really see their doctors for them to be treated. Same with those children with diarrhea who are given oral rehydrating solutions. Those children consume vitamin A supplement, at least high, because this is being given for free. Those who receive iron drops, it's lower among the poorest quintile. So, all in all, you could see here that the access of the poor to health services is very low, even though we are providing some of these services for free. And what are the problems in accessing healthcare by Wealth Index? So, this is based on the 2003 National Demographic Health Survey. And I think this is still true, kahit pa mag-isama to sa survey in 2008. Getting money for treatment is very high among those in lowest quintile. Having to take transport is also high. 57 among lowest quintile. It's only a problem of 12% in the highest quintile. Distance to health facilities, it's high for the lowest quintile. Only 13% for the highest quintile. Knowing where to go for treatment. So it means knowledge on where they can access treatment. Getting permission to go for treatment. No? Meaning to say, mother would still wait for the husband to ask for permission so that she can get the child to the health facilities. So it has something to do with women empowerment. Not wanting to go alone. Concern of absence of female providers and any of the specific problems. So these are concerns that are barriers to accessing health services that sometimes we have to know and we have to analyze. This slide tried to check the correlation of the presence of skilled birth attendants and maternal mortality ratio in the country. So, with this level of human resources at the regional level, this is the number of maternal deaths. This is ARM, this is Caraga. And what are the varying levels of under 5 mortality by demographic characteristics? So, more deaths among the rural areas and more among male than female. And then, more deaths among those with higher birth orders. So, kung yung bata ay pang-anim, pataas, no? There's more likelihood of dying. Mother's age at birth. The very young, less than 20%, the very old, also dictates the risk of dying of their children. And the previous birth interval, those that are delivering, getting pregnant every year, no? Every less than 2 years, their child's survival outcome is also very poor. So, we could see here that we have to focus on those rural areas. More on males. I really don't know why males. No? Birth order. No? Those that are more on the higher birth order in the family. No? The very young mothers, the very old mothers, the too frequent pregnancies. These are risk factors, that are demographic characteristics that would dictate the health of their children. And very important is the educational attainment of the mother. No? So, when you look at the neonatal, postneonatal, and child mortality, those with no education has higher risk. Those whose mothers have no education, the children have higher risk of dying before they reach 5 years old. Also with the poorest quintile. And when you look at the attendance at birth and place of delivery, based on our 2008 demographic health survey, only 62% are being attended by health professionals and only 44% delivered in health facility. That's why if we really would want to save our mothers and neonates from dying at that early age, we have to make sure that the deliveries are being attended by skilled professionals and they should happen at most at the health facilities. So, this is a fresh data from the recently disseminated 2008 National Demographic Health Surveys. And it is just to show us that those birth orders, pag medyo panghuli ka ng mga anak, no? Sabi nila latak. Most of these children are being delivered at home, which is very risky, no? So pinakita ko na kanina that higher order children have higher likelihood of dying before they reach 5 years old. And yet, when they are being delivered by their mothers, they are being delivered at home. childhood diseases, these are children under 5 with symptoms of respiratory infections in 2 weeks prior to preceding the survey of the 2008 NDHS. And we could see here that those percentage whom advice or treatment was sought from health facility or provider was only 50% among those children who had acute respiratory infection. And out of this, only 42% received antibiotics. And we don't know if these antibiotics are really adequately taken. No? Breastfeeding is also one of the very good intervention if we want to protect our Filipino children. But the breastfeeding status of children below 6 months old in the Philippines is not very good. No? So, those that are not breastfed are still 17%, although bumaba siya from 2003. But then, the exclusively breastfed does not move. No? Only 34% of our newborn are exclusively breastfed in the first 6 months of life. Some of them consume plain water only, and some of them consume other milk. And we know that breastfeeding and appropriate infant feeding can prevent 16,000 under 5 deaths, 1.2 million episodes of illness, 10 million days of illness, 450,000 health facility consultation, and 36,000 hospital admission. A very cost-effective intervention for child survival. Diarrhea treatment, this is also based on our 2008 NDHS. These are the interventions that are being given when child gets diarrhea. So, only 34% would seek care. 58% were given ORS. 35% increased fluid. Only 17% were given antibiotic. Some are still giving anti-motility. Now, the zinc supplementation, which is really evidence-based adjunct to diarrheal therapy, is only at a mere 1.5, no? STH, soil-transmitted helminthiasis. So, the prevalence rate of worm or parasitism among our children is very high. So, for 6 to 14 years old, the prevalence is high as 97%. And among our children less than 5, it's 66%. So, associated factors, poverty, poor nutrition, inadequate sanitation, and lack of clean drinking water. And if you're going to look at the prevalence of anemia among our children, it is very high among our 6 months to 1 year old and among our pregnant women. So, if the government will be investing for free iron supplement, then this would be channeled for our 6 to 12 months children or less than 1 year old children, our low birth weight infants, and our pregnant women. Underweights, our underweight children increase from 24 to 26. Our MDG target is at 17. What are other problems in the Philippines in terms of water and sanitation that affects child health? 2 out of 10 households, or about 16 million Filipinos, are without sustainable access to safe water supply. There are more than or close to 400 municipalities in the country still with no source of potable water supply. Increased reliance on water vendors, this is happening. And most of these, 12% of these increasing reliance to water vendors are living in urban areas. And irregular monitoring of water refilling stations and bottled water. 6, pero yan nga, yung mga nagpapadede sa bote, they're relying on bottled water. But we don't know how reliable are the water refilling stations within their localities. 6 out of 10 households with access to improved water sources face threat of water contamination, such as coliform bacteria, which cause large-scale community outbreaks. And 58% of our groundwater intended for drinking are contaminated with coliform bacteria and needs treatment. So 48% of pollutants come from domestic sources. So tingnan nyo yung correlation. 58% of our groundwater, which is the potential source of that water that we are drinking, are contaminated. And 48% of that contamination comes from our domestic waste. So, and out of 421 rivers in the country, 50 rivers were already polluted and 40 were biologically dead. In terms of sanitation, only 75% of our household have sanitary toilet facilities. And so this translates to more or less 20 million or 18 million Filipinos without sanitary toilet facilities. The existing sewerage and sanitation facilities are unsatisfactory and inadequate. And only about 4 have access to sewerage. Yung 4% na to, na may access sa proper sewerage system, 3% are in Metro Manila. No? So, 1% outside Metro Manila. And then there is low priority accorded to sewerage and sanitation over water supply. If you're going to look at the total budget of water and sanitation, not only in the country as a whole, only 3% goes to sanitation. Poor enforcement of regulation and still some practice open defecation. Hygiene, a simple hand washing is a very cost-effective intervention. This was a study done, I think, by UP, wherein they look at how often we wash our hands. So, and how many among us are washing their hands before eating? So, let's see. Before eating, 90% of adults are washing their hands. More than 50% of 0 to 12 years old are washing their hands. No? Before food preparation, only 1/4 of adults who are preparing foods are washing their hands. After using the toilet, only 1/5 of children 0 to 12 years old are washing their hands. only 37% of adolescents, only 44% of adults, and only 50% of older person. So, we thought malinis yung mga Pilipino, but when you look at how often they wash their hands, it is very low. We bath daily, and that's it, no? But we need a frequent hand washing practice. Now, 10 to 20% of foodborne disease outbreaks are due to contamination by food handlers. And if you're going to look at the economic cost of air, water, pollution, sanitation, now, you could see here, based on the Philippine Environmental Monitoring conducted by World Bank, we are losing $287 million per year economic loss due to reported diseases and reported deaths. And this is very, very big for a low-resource country like the Philippines. And if you're going to look at the health-related costs from poor sanitation, 91% would be due to premature deaths, 3% due to healthcare, and 5% productivity, the loss of productivity because of sickness or in death. How about financing? We would want to promote increased PhilHealth coverage, especially for the poor, to improve the financial protection of the poor. No? But you could see here that 38% of population, only 38%, have PhilHealth coverage compared to 30% in 2003 in NDHS. Now, we want the PhilHealth to validate this because they were saying that more or less we now have a universal coverage, meaning to say 80% of the poor are already enrolled. So this data showed otherwise. In sponsored program, the national average is only 22.1%. When we say sponsored program, these are the very, very poor families that are being enrolled for free by both the national government and the local government. And among beneficiaries belonging to the lowest and second lowest income quintile, only 73% and 49% are covered under the sponsored program, respectively. Meaning to say, there are some leakage in identifying the poor, and there is some leakage in the enrollment. Those that were identified as poor may not really be poor, and those that were really poor were not enrolled. So, what are the reasons for use of healthcare services? 68% when you are ill and injured. So, in other countries, the routine medical preventive checkup is the majority of the reason why person or family consult healthcare facilities. No? So sa atin, iba. Pag may sakit ka, doon ka magkonsulta. No? And then, only 28% for medical checkup, 1% for medical requirements, maybe for employment or for going to school, and then 2% for dental. Healthcare services by economic group, this is lowest among those poorest quintile, and more private healthcare increase with economic status. Cost of inpatient care, pag nagkasakit ka, the average cost of confinement is 16,800. Kung pupunta ka sa public facilities, the average is only less than 10,000. But if you go to private facilities, it is close to 25,000. So a big discrepancy. But let's look also at the quality of service between these facilities. Use of healthcare services by economic group. So, most of those that are seeking consultations are in private sectors are those in the highest quintile. Variation in use of healthcare services. So, among those who use healthcare services, it is highest in NCR. Maybe because the clinics here, the hospitals are really mushrooming, no? And it is lowest in Bicol. Use of provincial and district hospitals are highest in Cordillera. Use of rural health unit services, highest in Soxargen, lowest in CAR. Use of private hospitals, highest in Calabarzon, lowest in Bicol. So, if you want to have business for private hospital, you go to Calabarzon. Use of alternative and non-professional healthcare services, highest in Bicol. Okay, so all in all, in summary, what are the predisposing factors? Maternal and child nutrition, high fertility and short birth intervals, poor maternal care, insufficient newborn care, inappropriate infant and child feeding practices, poor access to safe water and sanitation, and poor access to basic health services. So, our package for survival, there should be skilled attendance at prenatal, natal, and postnatal care. Everybody should practice the proper essential newborn care protocol, which is already out. Infant and young child feeding, including exclusive breastfeeding, must be advocated by all health providers. Immunization, of course, is very cost-effective. Integrated management of childhood illnesses must be practiced at all levels. Micronutrient supplementation and deworming must be availed of. This vitamin A capsule and deworming drugs are being given for free. And therefore, we have to encourage our patient to avail of these free services. Birth spacing, injury prevention and control, which is an emerging concern for our children. Water sanitation and hygiene. And of course, the use of insecticide-treated nets, especially in malaria endemic areas. These are the essential health interventions for our child survival. package. Now, we say that, of course, financing, government financing is really a problem, as well as the personal financing of our clients. But then, at the government level, of course, there are so many lobbied groups for us to include this antigen in our immunization package, include this intervention for our immunization package. But you have to understand that we are using the data to guide us on how to use our minimal resources to good. So, now that we have some global economic crisis, my last parting word is that let's turn this crisis around and transform it into an opportunity for us to move forward. If having less makes us more focused and selective in our spending, in our interventions, or more rational in our choices, then this crisis would have served us well. So, meaning to say, it's not only a matter of pera, of money, of budget, but we have to make sure that we use our data to back us up in providing cost-effective intervention for our children. So with that, thank you very much and have a pleasant day.